In this lecture, we will discuss long QT syndrome, including its pathophysiology, 3 different types and their respective EKG features, as well as diagnostic criteria. Subtle differences in QRS, ST, and T-wave morphologies generally represent benign variations. However, in some cases, these changes may be diagnostic clues to identify rare inherited disorders that are associated with an increased risk of sudden cardiac death. These inherited disorders can have unique underlying mechanisms and presentations, but there are a few characteristics that they share. These characteristics include an increased risk of sudden cardiac death, as we mentioned. They also are associated with and are the result of functional mutations in ion channels, ion channel accessory proteins, or myocardial structural genes. They mostly appear in the absence of overt structural heart disease, and they have characteristic EKG patterns. And it's this last one, the characteristic EKG patterns, that help to differentiate these inherited arrhythmias. So in this lecture, we're going to focus on this long QT syndrome. With long QT syndrome, there is abnormal myocardial repolarization. This abnormal repolarization is a slow process. This prolongs the QT interval, just as the name implies, long QT, thereby increasing the risk of fatal ventricular arrhythmias, such as torsades de pointes. Okay, we can have the R on T phenomenon. So what we have going on here is a long QT. Remember, the QT interval is from the beginning of our QRS complex. So if you imagine here up until the end of our T wave, okay? So this area here is our QT interval, and we're saying that is prolonged. So it'd be from this point to this point here, okay? From this point to this one here. Okay, so the beginning of our QRS complex to the end. So it includes both ventricular depolarization as well as ventricular repolarization. All right. Now, long QT syndrome can either be inherited or acquired. If it's inherited, it tends to be the result of an ion-associated gene mutation. Currently, there have been at least 13 genes identified as loci for congenital long QT syndrome. Congenital just means that it's been inherited, okay, passed on to generations and present from birth. So the 3 major genes involved are KCNQ1, KCNH2, and SCN5A, and they represent the majority of cases, so we're going to focus on these ones. So these 3 genes have been subtyped and distinguished based on T-wave morphology, which we will discuss and look at shortly. Long QT syndrome can also be acquired. So we looked at the inherited. Now acquired forms, these are some potential causes of an acquired long QT syndrome would be medication exposure, electrolyte disturbances, or myocardial ischemia can also cause this. All right, so let's look at the EKG features we could expect to see with long QT syndrome. First, as you would expect, prolonged QTC interval is the hallmark of this disorder. The general cutoff is around 440 milliseconds for males and 460 milliseconds for females, okay? So now we're looking at the main thing, just as the name implies, the hallmark is this prolonged QTC interval. Remember, the QTC means corrected QT interval, and it corrects for heart rate. So the upper limit for the males is 440 milliseconds, okay? And the one for females is 460 milliseconds. So let's take a look at these here, just as an example. If we look from this point here, okay, up until this point here. Remember that 5 small boxes represents 200 milliseconds. So if we have one here, that's 5 small boxes, and then we have another 5 here and another 5. So there's about 15 small boxes. So if you imagine each one is 200 milliseconds times 3, we can see that 600 milliseconds is that QT interval, okay? So whether it's male or female, that's a prolonged QT interval. And you can see the same thing here from this one to the end of that, okay? There's 5 here, 10, and a little more, okay? You should know that if you think of it, 11 small boxes would be 440 milliseconds, okay? And that's that male upper threshold. So hopefully that makes sense. And that's the hallmark. The main thing is that prolonged QTC interval. So remember, when you look at the QTC interval, right, we can use the Bazet formula, okay? And we would take the QT interval, and we would divide that by the square root of the R to R interval. Okay, that's how you get that. And usually on the EKG strip, or you'll see that the QTC interval is oftentimes given to you. Okay. Now, it's important to note that the prolonged QTc interval is not the sole diagnostic criteria. In fact, about 25% of genotype positive long QT syndrome patients have a normal QTc interval. Furthermore, at least 2.5% of the general population will have a prolonged QTc interval. In general, if the QTc interval is greater than 500 milliseconds, patients are at a greater risk of sudden cardiac death. Okay, so once you get to 500 milliseconds, these patients are at an increased risk of sudden cardiac death, okay, the risk for the arrhythmia. Now, one other thing to note is that you should use the longest QTc interval for risk stratification because the QTc interval is dynamic and changes under different physiologic conditions, okay? So you always want to use the longer one, and it's often best measured in leads 2, V5, and V6, okay? So longest QT, all right? And then the best leads are 2, V5, and V6. Okay, when we talked about the QT interval, we mentioned how to measure it, the best way to measure it, and so forth. So you can go back and listen to that lecture, but those are the basics. Now, the second EKG feature to be aware of has to do with the T-wave morphology. If you recall, we said that there are 3 major genes that have been implicated in the majority of cases. They are the KCNQ1, KCNH2, and SCN5A. These 3 genes have been subtyped into 3 different types of long QT syndrome. Long QT syndrome type 1, long QT syndrome type 2, and long QT syndrome type 3. The KCNQ1 is involved in the first type, and the KCNH2 is involved in the second type, and SCN5A in the third type, okay? So you can see them here. KCNQ1 is with the first type, KCNH2 with the second type, and then SCN5A with this third type. Okay, so that's how we can differentiate the two based on the genes involved. Now, each of these types of long QT syndrome have been found to have subtle differences in their T-wave morphology. For instance, in the first type, which involves a loss of function mutation in the KCNQ1 gene that encodes for the alpha subunit of KV7.1, this represents a slow activating potassium channel. The T-wave actually has an early onset and is broad-based. Okay, so now we're seeing, well, how do we differentiate these 3 types? Okay, so here are the 3 types, and they're all going to be differentiated based on the T-wave morphology. Okay, and what we see here in this first type is that the T-wave, again, we have the prolonged QT. This is the hallmark, okay? And then the first type has an early onset, broad-based T-wave, okay? So you can see that here. Notice that our T-wave has a broad base. This is our T-wave, okay? And it's coming a lot earlier, okay? It's still prolonged QT. So that's the first type, okay? And then the second type, we have a mutation in the KCNH2 gene, which encodes an alpha subunit of the rapid activating potassium channels. And this results in T waves that are low in amplitude and are notched, okay? So the second type, low amplitude T waves and that are notched. And you can see that here. Here's our T wave. Notice you can see the notching of our T wave. So let me just erase that so you can see it, okay? Notice that there are 2 notches there. Okay, so that's our notched T wave present in this type 2, okay, and lower in amplitude. Lastly, the third type of long QT syndrome involves a gain of function mutations in the SCN5A gene that encodes the rapidly inactivating sodium channels NaV1.5. In this case, we will see a long isoelectric ST segment with a late appearing pointed T wave, okay? So this third type here, long isoelectric ST segment with a late pointed T wave, all right? So notice our ST segment's flat here, okay? And we see this late pointed T wave right there. So that's what we see in the third type, long QT syndrome type 3. So those are the 3 types of long QT syndrome in their variations. Now, when making a diagnosis of a long QT syndrome, it's important to keep in mind that a prolonged QTc interval alone is not sufficient to make the diagnosis. There must be an increased risk of sudden cardiac death. In order to assist with the diagnosis of long QT syndrome, a diagnostic score has been created known as the Schwartz score or the International Long QT Syndrome score. Okay, and I want to go through that here briefly. So you can see that here in the chart. Okay, and you can see that, so it's called the Schwartz score. and these are, it's a point system, and you can see the number of points you get based on it. So the first section has to do with the EKG findings, the second section is the clinical history, and the third is the family history. And then we'll take those points and add them up and get a score that will give us the probability that the patient has long QT syndrome or not. So the first one, the EKG findings, okay, have to do with the QTC interval, okay? In this case, we're using that Bazette formula. Remember, it's the QTC equals the QT interval over the square root of the R to R interval. And what you see, if it's greater than or equal to 480 milliseconds, you get 3 points. If it's between 460 and 470 milliseconds, you get 2 points. If it is 450 milliseconds and male gender, you get 1 point. If the if you have the QTC interval at the 4th minute of recovery from exercise stress that's greater than or equal to 480 milliseconds, you get 1 point. Okay, so in other words, you give a stress test, an exercise stress test to the patient, you have them slow down, recover, and if you look at the QTC interval at the 4th minute and it's 480 milliseconds or more, they would get that 1 point for that. Okay. If torsades de pointes develops at any point in this patient, they get 2 points for that. Okay, so that's pretty significant. If there's T-wave alternans, where the amplitudes of the T-waves are varying with each beat, okay, you get 1 point. If there's notch T-waves in 3 leads, you get 1 point. If the patient's heart rate is low for their age, especially in children, and the resting heart rate is less than the 2nd percentile for the age, they get half a point, okay? And then we want to look at the clinical history, okay? In this case, we're looking first if there's syncope. And you cannot receive these points for the syncope as well as for the torsades. So if they get 2 points for torsades, they don't also get 2 points for syncope. So it's one or the other. So if they develop syncope with stress, they get 2 points. If they develop it without stress, there's 1 point. And then, do they have congenital deafness? Okay, because some of these syndromes are related, especially with long QT syndrome, may be associated with congenital deafness. If that's the case, they get half a point. Okay, then you look at family history. Are other family members confirmed and have long QT syndrome? And that's why it's important to screen them, okay, and ask if there's any family history, because they get 1 point for that. Is there any sudden death in the immediate family members before the age of 30? If that's the case, you get half a point, okay? So again, you take all those points, you add them up. If it's less than or equal to 1 point, it's a low probability. If it's between 1.5 and 3 points, okay, that's more of an intermediate probability. And then if they're greater than or equal to 3.5 points, that's a high probability, okay? So again, keep in mind that a score of greater than or equal to 3.5 makes the diagnosis of long QT syndrome more likely, but again, is not diagnostic. All right, let's review what we discussed before we end here. So long QT syndrome is the result of abnormally slow repolarization, okay? And because of that, we get that prolonged QT interval, and these patients are at an increased risk of fatal arrhythmias. We mentioned torsades de pointes as one. Okay, can be inherited or acquired. If it's inherited, we mentioned 3 different genes that can be involved. Okay, and those 3 genes were associated with the 3 different types that we mentioned. If it's acquired, it can be from medications, electrolyte disturbances, or even ischemia. The EKG features, remember the hallmark was that prolonged QTC interval. For men, 440 milliseconds, and females, 460 milliseconds. Then we looked at the T-wave morphology, and that's what differentiated the 3 different types. Long QT syndrome type 1 had the early onset broad-based T waves. Long QT syndrome type 2 had the low amplitude and notch T wave. And then the third type had a long isoelectric ST segment with a late pointed T wave. Okay, and then remember, it's best to measure the QT interval, the longest one, and often in leads 2, V5, or V6 are the best ones to look at, okay? Then we mentioned the Schwartz score, which was a way to help give us the likelihood and help to make a diagnosis of long QT syndrome, okay? And we went through, it's a point-based system, and remember, if you have a score that's equal to or greater than 3.5, it makes the diagnosis of long QT syndrome more likely, but still not diagnostic. Remember, you need that increased risk of sudden cardiac death, okay, and hopefully that makes sense. Well, that's the end of this lecture. We discussed long QT syndrome, including its pathophysiology, 3 different types, and their respective EKG features, as well as diagnostic criteria. I hope you learned something.